discussing these problems and what are the solutions, we have none other than Dr. Chan Nair, who is the Chief Medical Officer at this hospital in Fort Washington. He is a senior board certified psychiatrist. So, Chan, over to you for the next aspects.
Thank you, Purvish. Um, Thank you very much, Dr. Rajay and Dr. Singh, for that really outstanding sort of communication, both personal and recommended medical. Just by way of introduction, I'm a psychiatrist. I'm a chief medical officer. I operate a health manager, 148-bed private standalone psychiatric hospital. And this is on the outskirts of Philadelphia, which is just south of New York and Jersey, and just north of sort of Baltimore and Washington, etc. So we're very much in the northeast of the US and very much in the red zone. We've been dealing with this since since March, like Dr. Nupur mentioned. And it has been a very trying time for all of us here, but in particular for the caregivers. I would basically just want to communicate my learning as both as a fellow physician, as an administrator, and as a father and a husband. Both my wife is a pediatrician. My oldest son is a cardiologist. He's actually at one of the local hospitals. He's the chief fellow. So in many ways, all three of us are sort of in the forefront as sort of caregivers for this onslaught, which I'm sure is the case with many of you guys. There are multiple aspects to the COVID crisis as far as psychiatry is concerned, but I would start out by saying that first and foremost, in fact, there's a prediction that a lot of psychiatrists will be required to be extremely supportive and sort of make sense of everything that's happening, both externally and internally, for our physician colleagues. In order to do this,
can I request you to come a little closer? The audio is a little poor, so if you can just.
Okay, I hope that's better.
Yeah.
Okay, so like I was saying, there are sort of several layers, several aspects of the pandemic that sort of put a lot of stress on our caregivers, and tending to them both individually and externally becomes obviously the purview and the responsibility of the psychiatrists in the community. So in order to do this, one of the first things I learned was, fortunately I had some training in internal medicine, some in sort of neurology, and that actually did help me communicate a lot with my colleagues so that you kind of know what they're talking about. And I think that I personally think that is very important so that your patients, and now when I say patients, I don't mean, I'm talking about caregivers being your patients. I'm talking about the intensivists, the pulmonary critical care, internists, the cardiologists, the anesthesiologists, who are actually in the forefront taking care of other patients with COVID-19 and who may or may not be COVID positive, which is also part of it. So the first aspect is what exactly happens psychologically to the caregivers. As is very evident to all of us, this becomes a day at a time kind of project where almost every day there's a new recommendations, new possible medication. Is it useful? Don't know. It may not be useful. It may be, in fact, a bad idea. So there's a lot of vacillation to and fro of therapeutic modalities, because basically we are, medically speaking, we're groping in the dark here in terms of what medically can be done for, patients who are seriously afflicted and critically ill. So this leads to a lot of confusion internally and a sense of loss of control for the physician. It leads to physicians traditionally are like a lot of structure. They, the one's cognitive or thought patterns are very clearly delineated, and ambiguity is not something that physicians handle very well, especially professional ambiguity. So the first thing that would happen is because of the ambiguity of the direction treatment modalities are to take and the rapid constant change, it causes a lot of internal stress in the physician who is the treater, be it an anesthesiologist, be it a pulmonary critical care person. So the physician is challenged into adopting a different mindset than something different from what he or she did earlier. And that is to sort of be open to change, which is very rapidly could seem contradictory to whatever earlier suggestions were. So that's number one. Number two is there could be a sense of helplessness. This is, in psychological terms, it's called learned helplessness. So one feels in the onslaught, in the ever-increasing seeming numbers, which from day to day to day keep climbing as things peak, one feels helpless because of the obvious high mortality and morbidity that one is dealing with. So one's efforts, despite being so taxing and so emotionally expensive, very often seem to sort of come to naught. So this induces a kind of internal sense of learned helplessness, as I mentioned. But a secondary symptom it induces is one of grief, and this grief that one feels for the loss of life of one's patients and the folks one sort of knows, or one could get attached to some of these patients emotionally. So that grief becomes sort of difficult to express, because there is no clear area where the physician either has the time or the opportunity to express it. So as a result of all these internal psychological stressors, what happens is, physicians sort of start also experiencing anxiety, panic attacks, insomnia, and inabilities to switch off, even after they go home and they undon or take off their PPEs and go through the procedures. There's another stressful setup. They're wondering whether they're bringing the virus back home to their family to infect their kids. And it becomes difficult for them to really switch off, and to sort of start afresh. So a sense of staleness internally, a sense of an eternal groundhog day where every day seems to be exactly like the previous one, except it gets more and more horrific, and leads to a lot of depression and sadness. Again, this depression and sadness and a sense of therapeutic nihilism, if you may. Therapeutic nihilism is, I'm doing everything I can, but it looks like I'm making no difference. People are, dying, and the infection is getting the upper hand, and more people are are sort of falling prey in this pandemic. That sense leads to underlying depression and what is called acute stress disorder, which is basically something like PTSD, but especially since it's ongoing and it's been less than 3 months, it falls into that diagnostic category. So a physician who's suffering from these will experience nightmares, will experience dreams in which he or she has, quote unquote, done something wrong, made a wrong clinical judgment, and as a result, there are going to be drastic consequences, etc. Such a physician would sort of jump out and wake up from sleep with nightmares, drenched in sweat, and have a hard time basically sleeping or getting adequate rest. And for a lot of physicians, these kind of personal internal states is very, very unusual, and it's very scary, and it leads to real clinical depression, which again there is no real avenue to express, because expectations from them professionally are way more than usual, and instead of less. So nobody's really going around asking physicians, how are you feeling? How are you sleeping? Are you able to get any rest? Are you able to switch off? Are you able to get any quote unquote me time? What do you do for recuperation? Nobody really, the physician is sort of expected to take care of himself and herself. So this becomes a major problem. I personally have a whole bunch of friends who are sort of in the trenches, dealing, as I said earlier, two of them are critical care pulmonology, and one is a frontline anesthesiologist, and they do call me. I have in fact told them that they can call me anytime, 24/7, and I would be happy to talk to them. I have in fact prescribed medications for sleep and for basically encouraging some rest and recreation in their precious times off. Because the other thing with frontline staff is they are sort of working on tier system. So in order not to exhaust all the frontline staff, there are folks who sort of work through 2 weeks at a stretch and then sort of go home after that and get like 2 days or 3 days off, and then they have to come back into another tier. So the inability to switch off, inability to recuperate also becomes a major cause. Finally, there are a lot of I personally had also, you have other physicians you're close to who actually pass away, as I did. One of my psychiatrist colleagues, who was just 61 years of age, when he was an outpatient psychiatrist, so there was positive plasma, and he got 2 transfusions of that, but despite that, he passed away. So, you had the added burden of another sort of demise of somebody very close to you in the front line, whom you couldn't help with. So, bottom line, my time is almost up, but what I do want folks to know that it is imperative that we seek help when we think we are sort of spinning out of control. For this purpose, in the US, there are several sort of support lines. The one and only one that I mentioned here, it's just one of several, is actually a volunteer line where trained psychiatric physicians who are also fairly good empathic therapists volunteer their services 24/7 for other physicians. We need to protect ourselves, our brothers and sisters who are in the front lines. We need to make ourselves available. We need to have a common language And in these difficult, trying times, we need to basically take it a day at a time and be ready for anything and directions to change real rapidly. And basically stay fluid within oneself. Be open and be kind to oneself. To realize we too are human, and that we need to protect and take care of ourselves, because otherwise nobody else will know how to do it for us. That's about all I had to say. There's of course plenty more, but we can take it up some other time. I thank you for the opportunity.
Thank you very much,